Important operative steps during the cholecystectomy and their purpose. First of all, the retraction. Proper retraction in the correct direction. The fundus is retracted towards the patient's right shoulder and the infundibulum is retracted inferiorlaterally towards the patient's right side. Now, what is its purpose? It opens the hepatocystic triangle, increases the angle between the cystic duct and the CBD, which limits the dissection above the Rouvier circle. Mental and spatial or orientation of the anatomy, variation and landmarks. The second step, we have to look out for the red flag signs. Those are failure of timely progression of the dissection, anatomical disorientation, difficulty in visualization of the operative field. What is its purpose? Timeout. The surgeon should recognize these clues, stop dissection and decide on the strategy for safe operation before proceeding. Do not hesitate to seek a second opinion in this case. Other is this, which is the most important step, that is to achieve the critical view of safety, CVS. Clearance of the hepatocystic triangle of all the fibrofatty and soft areolar tissue to see the only two structures entering the gallbladder, that is the cystic artery and the cystic duct. What is its purpose? And if we find any difficulty achieving the critical view of safety, it is a warning. The further dissection may be hazardous with an increased risk of biliary or vascular injury. We should stop and reconfirm with a team second surgeon that the CVS has been, when the CVS has been achieved, then only we should proceed with the further findings. It may be documented by the photographs or video recordings. Exposure of the cystic plate. This is done by separating the gallbladder from its liver bed to expose at least the medial third of the cystic plate. Separate the gallbladder from the fossa. This is done by leaving the cystic plate attached to liver. What is its purpose? It is to avoid bleeding from the liver, sinuses and bile. Now, what are the complications during cholecystectomy? What are the complications during cholecystectomy? First of all, bile duct injury, which is most common. Here you can see this is a schematic representation of uh, Strasberg's classification of bile duct injuries. In the figure A, we can see a bile leak from the cystic duct. As you can see, the bile is leaking from the cystic duct. Bile is leaking from the cystic duct stump, or it is a minor biliary radical in the gallbladder fossa. In the figure B, as you can see here, an occluded right posterior sectoral duct. In the figure C, a bile leak is from the divided right posterior sectoral duct, as you can see here. In the figure D, there is a bile leak from the main bile duct without any major tissue loss. And as we move down, in the E1, as you can see this E1 figure, transected main bile duct with a stricture less than 2 cm from the ileus can be seen. In the E2 figure, as you can see, transected main bile duct with a stricture more than 2 cm from the ileus. In the E3 figure, we can see transected main bile duct with a stricture less than 2 cm. In the E4, E4. तो सर एक्सप्लेन करने की ज़रूरत नहीं है. With this, I would like to call my next presenter who will present with the complications of a cholecystectomy.
Good morning, respected dignitaries, esteemed faculty members, and my fellow colleagues. I, Jayant Yadav, along with the support of my team members Adhar, Aman, Ananya, and Divyanshi, am here to present our topic, Complications of Cholecystectomy, under the guidance of Dr. Sanjay Singhal Sir, Head of the Surgery Department, and Dr. Neel Kamal Gupta Sir, as part of the 17th UGCR. To begin with, cholecystectomy or gallstone disease can result in a range of complications if poorly managed or left untreated. In this presentation, we will discuss these complications under the headings as shown, with an aim to understand the pathogenesis, clinical features, investigation, and management of each complication. With this in mind, let's first look at a very common presentation, biliary colic. Biliary colic results from transient obstruction of the cystic duct, typically after a fatty meal, leading to contraction against the blockage causing pain. Patients typically present with sudden severe right upper quadrant pain, which radiates to the right shoulder or scapula. The pain usually resolves within a few hours as the stone dislodges. Investigations primarily involve an ultrasound scan, which shows gallstones without signs of inflammation. Management includes pain control using NSAIDs or opioids if the pain is too severe. Elective laparoscopic cholecystectomy is recommended to prevent recurrence. We now move on to an inflammatory complication, cholecystitis. Cholecystitis, both acute and chronic, results from persistent cystic duct obstruction, leading to biliary stasis, inflammation, and eventual fibrosis in chronic cases. Patients commonly present with right upper quadrant or epigastric pain, fever, and a positive Murphy sign, which is indicated by pain and an abrupt halt in inspiration as an examiner palpates the skin above the gallbladder. Ultrasound typically reveals gallbladder wall thickening and pericholecystic fluid. Lab findings may include leukocytosis, an elevated CRP level, and an abnormal liver enzyme pattern. Management involves early laparoscopic cholecystectomy with analgesics and antibiotics as needed. Unresolved gallstones may progress to a suppurative condition known as empyema. Empyema of the gallbladder occurs when there is superinfection with organisms such as E. coli, Clostridia, or Bacteroides, which leads to pus accumulation inside the bladder. Patients typically present with a marked right upper quadrant pain and a high-grade fever. Diagnosis is confirmed through ultrasound or CT, and lab findings will show leukocytosis and elevated inflammatory markers. IV antibiotics targeting gram-negative bacteria and anaerobic bacteria are administered urgently, followed by an early cholecystectomy or percutaneous drainage if the patient is a high-risk one. Mucocele. It results from cystic duct obstruction without superinfection, leading to mucus accumulation inside the bladder, leading to mucus accumulation and gallbladder distension. Clinically, it is often asymptomatic or may present with mild discomfort, sometimes accompanied by a palpable non-tender mass in the right upper quadrant. Ultrasound shows an enlarged fluid-filled gallbladder without any stones or any signs of inflammation. A mucocele may be managed through an electrocholecystectomy to prevent any further complications. Perforation typically follows necrosis of the gallbladder wall due to prolonged inflammation. It may either lead to a localized abscess or a generalized peritonitis. Key clinical features include a sudden worsening of pain with possible signs of sepsis and peritonitis such as tenderness and guarding. A CT scan is the investigation of choice and may reveal fluid collections and abscess formation. Emergency surgical intervention is required, often in the form of abscess drainage and an open cholecystectomy. A complication involving the biliary tree is cholelithiasis. This condition arises when the gallstones migrate into the common bile duct, causing biliary obstruction and may also potentially lead to ascending cholangitis if an infection supersedes. Clinical presentation includes the right upper quadrant pain, jaundice, and the classical Charcot's triad of intermittent fever, intermittent pain, and intermittent jaundice. In severe cases, additional hypotension and altered mentation, along with the Charcot's triad, may form what's known as the Reynolds pentad. Investigations include liver function tests, which show an elevated direct bilirubin level and an elevated GGT level, and imaging modalities such as magnetic resonance cholangiopancreatography, or MRCP, or a more invasive endoscopic retrograde cholangiopancreatography, or ERCP. Treatment involves ERCP with stone extraction, which may be followed by cholecystectomy. A potentially serious complication is gallstone pancreatitis, which results from transient ampullary obstruction, which triggers enzyme activation and pancreatic inflammation. Patients often experience epigastric pain, which radiates to the back, which may be relieved by leaning forward. Additional signs include nausea, vomiting, and systemic features such as tachypnea and tachycardia. Lab tests show elevated amylase and lipase levels, and a contrast-enhanced CT scan is the best diagnostic tool, showing enlarged pancreas and signs of biliary obstruction. Management is supportive initially, including fluids, analgesia, and adequate bowel rest. ERCP is considered if biliary obstruction persists, and a cholecystectomy is done subsequently. Now let's take a look at gallstone ileus. It's a condition that arises from chronic inflammation, which creates a fistulous connection between the gallbladder and the intestine. Large stones pass into the bowel and cause mechanical obstruction, most commonly at the ileocecal valve. It primarily affects elderly people and presents with vomiting, abdominal distension, and an intermittent colicky pain, a phenomena which is also referred to as tumbling ileus. Radiological findings include the regular striate on an X-ray, which is represented by pneumobilia or presence of air in the biliary tree, small bowel obstruction, and an ectopic gallstone, which is seen as a radiopaque shadow very commonly in the right iliac fossa. CT imaging is the most sensitive diagnostic tool, and treatment involves enterolithotomy with cholecystectomy and fistula repair, be it one stage or two stage. Closely related to gallstone ileus is a biliary enteric fistula, which we will now discuss. This refers to formation of a fistula between the gallbladder and the gastrointestinal tract, with most commonly the duodenum. It often results in stone migration into the bowel, causing similar obstructive symptoms as seen in gallstone ileus. Patients, typically elderly females, present with colicky abdominal pain, vomiting, and a history of biliary colic. CT abdomen is the most sensitive tool, demonstrating the regular striate. Initial treatment is enterolithotomy with definitive cholecystectomy and fistula repair, performed either simultaneously or later. We will conclude our presentation with Mirizi syndrome, a rare yet serious complication of cholelithiasis. Mirizi syndrome results from stone impacted in the cystic duct or the gallbladder infundibulum, compressing the common hepatic duct or the bile duct externally. Patients present with right upper quadrant pain and obstructive jaundice. Lab findings include elevated bilirubin levels, and imaging with MRCP or ERCP may show the classical meniscus sign. Management involves preoperative ERCP, possibly with stent placement, followed by cholecystectomy, which may be either open or laparoscopic. To summarize, cholelithiasis may lead to a wide spectrum of complications if left untreated, ranging from biliary colic to potentially life-threatening conditions like pancreatitis. Timely diagnosis and appropriate surgical management are crucial to prevent morbidity.